So Mohs surgery is, again, a very highly specialized and surgical technique where what we do is the patient comes into our room and we look at the area. Typically they've had a biopsy of a skin cancer, and we draw a circle around that area and we take that area out in a layer. Once that specimen has been removed, we take that specimen across the hall to our laboratory, and that's where we have our amazing histotechnicians process it in real time and lay it down flat so that I can look at 100% of it. In the meantime, the patient is usually bandaged and waiting, and in that time period I look at the specimen under the microscope for residual cancer. If I see any residual cancer on that specimen, then we'll have the patient come back and we'll take an additional layer. If the patient's specimen is free of cancer cells, then they're clear and the cancer is gone. At that point, then we have the patient come back and we do reconstructive plastic surgery. If there's still cancer left, we bring the patient back and take an additional layer, and that process repeats itself until all of the skin cancer is gone. So that's typically how it works. So we're able to function as the Mohs surgeon, as both the surgeon and the pathologist, and then most of the time as the reconstructive surgeon as well. So it's very convenient for patients and for physicians, knowing that the patient is cancer-free the same day, knowing that the recurrence rate is usually less than 1%, and also getting stitched up the same day. It's a win-win for everybody. So a traditional excision typically involves taking a predefined margin of skin around where you see the visible skin cancer with the naked eye. So for example, if you have a spot on your cheek that has been biopsied in the past, what a traditional excision involves is taking about a 4 to 5 millimeter margin of normal skin around that circle and taking that out as usually a ellipse, so to speak, or a diamond shape. And then you submit that tissue to a regular lab off-site, not a Mohs lab. That's generally pretty good for areas on the trunk, the arms, areas where there's a lot more tissue or real estate, areas that are not as cosmetically sensitive or functionally sensitive. Those traditional surgeries are still very good. But a couple caveats with that. One, you're taking a predefined margin, so you don't know for sure if you've got it all. You just essentially are using statistically backed data to show that a margin of 4 to 5 millimeters typically gets most of it, but you don't know for sure. The other caveat is the processing that takes place with that specimen is different than the Mohs processing. So the processing of that involves analysis by a pathologist that typically examines less than about 1% of that margin or of that specimen. Whereas with Mohs, micrographic surgery, we examine the whole 100% margin, so to speak. So there's subtle subtleties that make Mohs more superior from a pathologic evaluation, for example, for basal cell carcinoma. But excision is still pretty good for regular routine skin cancers on the trunk and extremities. Exactly. We want to get the best treatment option that's going to conserve the most tissue in those areas. For example, around the eye, anywhere on the face, but especially around areas that are very sensitive. So Mohs surgery offers the ability to remove skin cancer by conserving normal skin tissue and again examining 100% of the specimen we take out to make sure that it's gone. Usually for the first 48 hours, 24 to 48 hours, we have what's called a pressure dressing that's taped on, usually fairly firm, to help prevent bruising and swelling and bleeding postoperatively. Now you're still going to have some bruising and some swelling, that's natural, but ideally not too much bleeding. That's for the first day or two. Then after that, that pressure dressing typically can come off, and for the next usually 5 to 7 days for areas on the face, You just want to have the patient take it easy, and then they come in, and if they've had sutures that need to be removed, we'll have them come back at that time after about a week and remove those stitches. At that point, it's usually just Vaseline and keeping it covered from the elements and from sunlight while they're healing up as much as they can for the next few weeks. And that swelling and bruising typically goes down. Like I said earlier, that can take at least 2 to 4 weeks. I always tell patients, especially for the bigger reconstructions, that can take upwards of at least 2 months. Usually it settles down though and looks great at about the 3-month mark. But yeah, no, that's a great question. And again, from a pain perspective, most of the time for routine small skin cancers, Tylenol and ibuprofen are just fine. Photoprotection is key, whether that's through sunscreen or photoprotective clothing. Certainly in the summer months, between the hours of 10 and 2 typically, you definitely want to have some form of photoprotection, especially if you're outdoors quite a bit. But even if you are indoors, I like sunscreen. I like mineral sunscreen, zinc or titanium-based sunscreens, and I wear them every day. Highly recommend them, but they do make photoprotective clothing too out there, especially for your arms, legs, hands, wide brim hats to cover your head, your ears. Definitely want to be photoprotected as much as you can, especially when you're younger. If you start doing that younger, then ideally you can help prevent getting the more common skin cancers later on in life, such as basal cell carcinoma and squamous cell carcinoma. But yeah, definitely sunscreen, big proponent of.
What about in and out of the water, reapplying?
Yeah, so the main thing with that, people in general are pretty good about applying sunscreen one time. They are not as good at reapplying. So usually we say every 2 hours at least, you want to reapply sunscreen. Or if you're in the water and have a lot of, or you're sweating a lot and that sunscreen is coming off a lot faster, you definitely want to reapply as much as you can. Certainly areas that I see people miss are the tops of their ears, their eyelids, their lips, the tops of your hair, where your hair is going back like mine. You want to hit those areas too, and then their necks as well. And certainly hands. We see a lot of skin cancer on the hands and fingers. Yeah. So good question. Reapplication is key. I'm very blessed to be a Mohs surgeon. I'm very grateful to be where I'm at today. It's very fulfilling and rewarding to offer patients a treatment modality that is the gold standard for most skin cancers. And it is very satisfying knowing that at the end of the day, when your patient leaves, that they are cured of their skin cancer with a 99% cure rate, which is very satisfying. That is the convenience. It seems like sometimes, a lot of patients come in and they may or may not realize that we ask them to be here all day, and typically they're not. But it is much more convenient to treat the skin cancer, have the patient be here with us for the day to make sure that we get that 99% cure rate. That way, if we did a traditional excision and it didn't get it all, they don't have to come back later on. So it is convenient and assuring that we got everything that one day.
Yeah. At the end of the day, or as they're leaving your office to walk to the car, they know.
They know.
Everything is fine.
That everything is fine, that they have been cured of their skin cancer.